into the void and unable for you to not be able to hear me. So please let me know. Like Diane said, my name's Liane Campbell, and I'm a pediatrician with Global Health Corps. I was in Mbeya, Tanzania from 2011 up until March. I'm currently in Colorado in the United States, but hoping to get back to Tanzania soon. So I thought it might be interesting to talk today a little bit about some pediatric considerations, particularly in the resource-constrained setting. So what we're going to talk about today, we're going to talk a little bit about some considerations where COVID-19 testing is limited, which I think is a lot of the globe. There's a lot of variation in how limited it might be. With limited COVID-19 testing, I think it can be useful to review some of the clinical presentation of COVID-19 in children. We'll also talk briefly about the new multi-system inflammatory syndrome in kids. And then we'll kind of take it a step further. So if COVID-19 is in your differential diagnosis, what do you do next? And we'll focus that more on outpatient management of mild cases, since Jamie last week talked about management of severe and acute cases. And then we'll wrap it up just with a little look at the secondary impact of the pandemic on children's health globally. So first, I thought it was interesting to kind of try to conceptualize the COVID-19 testing cascade. So this is how I conceptualized it. I thought we'd go through, and then on the next slide, I'd love to hear some of your feedback about what I maybe missed in this cascade, what's working well, what isn't. So basically for a patient to go all the way from symptoms to getting the results, all steps in this cascade need to be functional. So on the one hand, I put steps, and then I put challenges I could envision in the other side. So your patient needs to notice symptoms, they go to a health facility. There could be difficulty with transportation to the health facility. There could be fear of visiting healthcare facilities, especially in the situation of a pandemic. Health facilities could have limited hours or personnel. Then the healthcare worker needs to suspect COVID-19, which they might not do, especially if there's really limited national data, and it's hard to know how big of a problem is COVID-19 in your nation. Then your healthcare worker needs to, order their COVID-19 test, or maybe depending on the way it works in your nation, they need to contact the COVID-19 team. And that depends on the COVID-19 team being functional, upon supplies to perform the test being present, on whether or not the patient qualifies for testing based on the national algorithm. The specimen then may need to be sent to a lab, particularly if testing is centralized around one part of the country. That could be a long distance from your site, where the lab needs to be able to process the specimen, and that is dependent on having lab reagents, equipment, lab workers. Some countries have had some political involvement in testing and reporting, which could be another barrier. And then the lab needs to be able to send results back to the healthcare worker, and the healthcare worker can locate the person, which means you need a functional system to be able to return results to the ordering healthcare worker, and then they can actually find that person. So that's kind of how I conceptualize the COVID-19 testing cascade. And I'm curious from the sites, how is this going? Maybe as a simple question, has anyone been able to obtain a COVID-19 test result for a patient that you're caring for at your site? Maybe if we could get a thumbs up emoji if that has happened. Don't know. Let's see. Looks like maybe.
Oh, there's one from Godwin.
Okay.
Eswatini.
Great. Maybe as I'm talking as well, you can think a little bit about any barriers to this process or successes to this process, and we can chat more at the end. But I conceptualize this as a challenge, and that it might lead to a situation where you might essentially have no COVID-19 test, or you might be in a situation where results take a very long time to return, and that could lead to challenges. I think a lack of testing can make us feel like we're kind of in the dark. That it's hard to know how many cases are in the particular area where we're practicing and how big of a problem it is. And one strength I feel of the BIPAI network is we have a lot of diversity. There's a wide range of available resources at the COE sites across the network. And with that, there's also a wide range in availability of COVID-19 testing across the sites. There's a big variation in national approaches to the pandemic. Just kind of for context, I put up there the list of the diagnostics that we have at the MBA COE. There's other diagnostics available if patients can pay, but the list of what you see there is kind of what we have, on the ground that patients could access for free, and that it's very limited. So with very limited diagnostics, we frequently use a differential diagnosis when we're approaching patients. I can think of many times when I and other clinicians are thinking about a patient and we think to ourselves, what are some possible causes for our patient's symptoms? I think it's always important to try to think, what is the most likely diagnosis? What is the most dangerous diagnosis? And then think about how you can evaluate and treat the conditions on your list with what you have available. A lot of times we say, don't let perfect be the enemy of very good. You might not have all the diagnostics you'd like to have, but maybe you have some of them. You have ability to take a good history and try to use that to narrow your differential diagnosis as best you can. In the situation of a pandemic, I think it's good for COVID-19 to be, in the back of our minds as we're thinking about a differential diagnosis for our patients. So with that, I thought it might be helpful to take a little look at some of the clinical features of COVID-19 in pediatrics to see if they could help us as we're approaching the differential diagnosis. So we'll talk briefly about some common symptoms. We'll talk about some dermatologic findings, which also will include some skin findings in adults. We'll talk a bit about COVID-19 in infants. And at that point, we'll take another pause, and I'd love to hear back from the sites if you're seeing patients with some of these features, any differences of what you're seeing. We'll then touch briefly on the new multi-system inflammatory syndrome in kids. So that's where we're going next. So first of all, I was wondering if there are features from the history that can help you when you're considering whether or not COVID-19 should be on your differential. And one question that I thought could be helpful would be asking about sick family members. This table comes from some initial data from China looking at kids with COVID-19. And they found in that group of kids, an exposure in the family cluster was present in about 90% of them. There was only about 9% of children who had an unidentified source of infection. So asking about sick family members and getting information that other people in the family are sick could help you in thinking about if COVID-19 should be on the differential diagnosis or not. I think earlier in the pandemic, travel was a really big question. Now, as the disease has spread globally, and particularly in places where there's really limited testing, I think the travel question might be more or less helpful for you. It could be helpful if you have good national data about what the epidemiology is in the country, or it might be less helpful if there's really limited testing data that's shared. This table is from a comparison of 4 different pediatric cohorts. It was part of the discussion from an article published sharing the information from Italy, where they again looked at exposure within family cluster or an unknown exposure. And amongst the Chinese data as well as the US data, again, very high percentages of children had an exposure from within their family cluster. In contrast, the Italian patients had only about 45%, in which they had a known exposure within their family cluster. The authors thought this was due to a later lockdown in Italy, and so children had a chance to be exposed to the disease outside of their family. I know our BIPAI sites have had a variety of approaches to lockdowns, and so this may vary based on the site, depending on what is happening in the nation. Then thinking a little bit about what are some common symptoms. We've talked before about fever, cough, shortness of breath being common symptoms among children as well as adults. But this table comparing pediatric and adult data in the US really, I think, highlights how children are not presenting with these classic symptoms of fever, cough, and shortness of breath quite as often. You can see in the column that adults are presenting with those symptoms in about 90%, over 90% of cases, whereas only 73% of children had one of those symptoms. And when you look further at fever and cough specifically, only about 56% of patients presented with fever, only 54% presented with cough. So I think this is helpful to remind us that not all pediatric patients with COVID-19 will have fever or cough. If part of the way we're screening for COVID-19 patients is specifically looking at fever, we could miss patients who are presenting without fever. And again, going back to this comparison of pediatric cohorts, looking at fever specifically in some of the Chinese data, only 41% presented with fever, 54% amongst the Italian data. Interestingly, in the Italian cohort, 23% presented with no feeding or difficulty feeding. The median age of patients in their cohort was a bit younger. It was about 3 years in comparison with 6 and 7 in the Chinese cohorts, and then a median age of 11 in the US cohort. So that might have been why this difficulty feeding was a more prominent symptom. Again, GI symptoms such as nausea, vomiting, or diarrhea were present in about 10 to 12% of cohorts across the board. So that's another symptom that should cause you to think about COVID-19 in your patients. There are certainly other clinical manifestations. This case series from China presented 5 cases in which patients presented to the emergency department with an emergent non-COVID related condition, one with intussusception, one with gastroenteritis, one patient had a subdural dural hematoma, one had appendicitis. All of them had chest CT findings that were suggestive of pneumonia and then were later found to have COVID-19. And when they went back and looked at these cases, all of them had GI symptoms initially. So again, kind of highlighting the importance of thinking about GI symptoms. Other symptoms that have been described include chills, myalgias, headache, congestion, and new loss of taste or smell. So are other things that might point you in that direction. And then thinking about some skin findings, I'm going to show you pictures of these descriptions in a moment, but there was a study in Spain where dermatologists looked back at about 400 patients, and they tried to classify rashes of those patients with COVID-19 into, they felt they could be categorized into 5 different subcategories. And in particular, the first category, the pseudochilblain, was associated with less severe disease and tended to occur later in symptoms. Some of the other categories, vesicular eruptions, or similar to a chickenpox appearance, happened earlier in the course of illness. And then the last category, or livedo, happened with more severe disease. So the pseudochilblain, here's some photographs of it, tended to be asymmetrical, involving the extremities, and tended to occur in younger patients. In their group, it happened in their group of patients who had this presentation had a median age of 32. There have been other pediatric brief case series describing this specifically in kids, both from Spain and Italy. So this subtle finding on the hands and feet might trigger you to think more about COVID-19 in your patients. Some of these other adult, other rashes that they saw, vesicular eruptions, urticarial eruptions, and maculopapular eruptions tended to occur earlier in the course of illness. And then the last picture of livedo happened in patients who were very ill and oftentimes had other veno-occlusive disease. And then thinking a little bit more about COVID-19 in infants, infants have been described as presenting as fever without respiratory symptoms. There was a brief case series of 5 infants in France who presented with fever. They had no respiratory symptoms. These 5 infants also had some neurologic symptoms, either hypotonia or ataxia. They got lumbar punctures, all of which were negative for COVID-19. And all the infants were treated with paracetamol and resolved. 2 cases in New York, one infant presented with fever and a rash, and the other presented with fever and a low lymphocyte count. Both patients also did well. And then there was a case series of 9 infants from China Four of those infants presented with fever, 2 had some mild upper respiratory tract symptoms, 1 had no symptoms, and then 2 had no inflammation. All 9 infants did well. None had developed severe disease or required critical care interventions, and all of them had, sick family members. I thought a little bit about, are there other diagnostics that might help you, that you might have available? Some of the initial data from Wuhan did describe low white blood cell counts in 25% of the patients. Some other case series have had varying amounts of low white blood cell counts. So some other cohorts have described low white blood cell counts in a less percentage, ranging from 9 to 16%. So that could be helpful if you see a low white blood cell count, but maybe not, doesn't necessarily tell you that for sure it's COVID-19. In the Wuhan group, some patients had elevations of inflammatory markers such as a procalcitonin or a CRP, but again, not in huge percentages of patients. And then X-ray as well can have really variable presentation. This case series looked at 9 pediatric patients. Of these 9 pediatric patients, 6 actually had normal chest X-rays. 3 of them had some bilateral bronchovascular shadowing, which is shown in the X-rays in the top of the screen, and some hilar shadowing, but again, pretty non-specific and subtle findings on a chest X-ray. The good news, we've talked about this before, but what we've seen so far is that the frequency of severe disease in children tends to be in a small percentage, smaller than that of adults. Most kids are getting a mild or moderate disease that resolves after 1 to 2 weeks. This data is kind of some of the very earliest data we saw from China, and it's true in this group amongst infants less than the age of 1, a higher percentage had severe or critical disease, but the study authors and other reviewers have commented that it's important to interpret this specifically with some caution, as a lot of these severe and critical infants didn't have viral testing to confirm that COVID-19 was what made them so sick. So again, risk factors for severe disease: infants under the age of 1, definitely children with serious underlying conditions, such as chronic pulmonary disease, cardiovascular disease, or immunosuppression. This review, looking at characteristics and outcomes of children with COVID-19 admitted to PICUs in the US and in Canada, described 48 patients, and of those, 40 had a serious underlying condition, with medical complexity or dependence on technology being the most common, followed by malignancy and then obesity. Other conditions that have been predictive of severe disease in adults include obesity as well, chronic kidney disease with dependence on dialysis, or chronic hepatitis. So those might be things that would prompt us in our patients to be more worried about them developing severe disease. So now I'd like to take a quick pause and see from the sites, are you seeing any patients with these clinical features or an increase in patients with these clinical features at your sites? Could you get a thumbs up for yes?
And also, Liane,
yeah,
your camera is angled a little farther down again. So either, yeah, perfect. Now we can.
Is that better? Okay, great. Thank you. And if any, or not seeing any patients with these features, we know that there's a lot of variety about what's happening around the globe, or seeing any caregivers with any of these clinical features. Right. You can think about it, and if you have more thoughts towards the end, I'd love to hear more from what the sites are seeing. I'll keep going. And I thought we could talk just briefly about the new multisystem inflammatory syndrome in children. This was first described in late April and appears to be a rare complication of COVID-19 in kids. It's gotten quite a bit of media press. I put a couple of headlines down at the bottom. In UK and Italy, they described a lag of several weeks between a peak of COVID-19 cases to a peak of MIS-C cases. which caused them to theorize that it might be a post-infectious complication of the virus. With this being a new syndrome, I think that the information and what we're learning about it is changing really on a daily and weekly basis. So I feel like the information I share may be obsolete and changing over the next week. So it's definitely an area where there's lots of new research going on and lots of new information arising. A review of the cases that we have available so far, looking at some of the symptoms. Persistent fever was present in 100% of patients. Many patients presented after 3 to 5 days of persistent fever and then had signs and symptoms of warm shock, which was fluid resistant and ultimately required vasopressors. Gastrointestinal symptoms were also very common, present in about 60 to 97% of patients. Some patients presented with symptoms of appendicitis. And actually, I even underwent laparotomy trying to figure out if they had appendicitis or not. Rash and neurocognitive symptoms were present in a kind of a medium percentage. Respiratory symptoms were not the most prominent. Some patients did require mechanical ventilation for cardiovascular stabilization, but in most patients, respiratory failure wasn't their primary presentation. Thinking about some of the clinical findings, about 60 to 80% presented in shock. I think reading about patients with this condition was a reminder that these patients are quite ill. If you look down below in the available case series, about almost 70% of patients in some case series required a non-invasive or invasive ventilation, so CPAP or BiPAP or an actual ventilator. Myocardial dysfunction, as defined by changes on echocardiogram or changes in cardiac enzymes, were present in a lot of patients. And about 50 to 64% of patients met criteria for complete Kawasaki's disease. And I thought it might be useful to just review what is Kawasaki's disease, because a lot of people are talking about this condition, how it's similar or different to Kawasaki's disease. I put at the back of the presentation that we won't go through some additional slides that might help you with some information about Kawasaki's disease, about toxic shock syndrome, which is a common thing on the differential diagnosis for this condition, and some treatment algorithms for Kawasaki's disease. But Kawasaki's disease is one of the most common vasculitides of childhood, and symptoms arise from inflammation of medium-sized muscular arteries. To meet criteria for Kawasaki's disease, patients need to have fever for at least 5 days, and then 4 or 5 of the following physical findings. So bilateral conjunctival injection, which you can see in the photograph there. Oral mucous membrane changes, which might be cracked or fissured lips, or a strawberry tongue. Peripheral extremity changes, which could be a rash involving the hands and the palms and soles, or swelling of the hands and feet, or desquamation, which is a late sign. A polymorphous rash, and then cervical lymphadenopathy. In contrast with classic Kawasaki's disease, what people are seeing so far with MIS-C is that it seems to be impacting school-age children and teenagers at a greater frequency, with Kawasaki's disease more frequently impacting young children or infants. Also, Kawasaki's disease is more commonly seen in children of Asian descent. What we've seen so far is that MIS-C may impact children of African heritage more frequently, but again, this is very, very new information and just some limited case series so far. And that has caused people to think about COVID-19 as perhaps a spectrum of disease. This slide is from a CDC clinician outreach call that happened last week. And as we learn more about MIS-C and COVID-19 in children, I think the spectrum of disease and our understanding of it will likely change. But one way to think of it is that in many kids, COVID-19 is generally mild or asymptomatic, but that some children may get what's a febrile reaction with inflammation that's temporally associated. Those kids may have persistent fever and headaches and elevated markers of inflammation, but don't have signs of Kawasaki's disease or multi-system organ involvement. Some patients may have Kawasaki's disease associated with COVID-19, but not have signs of shock. And then some patients may have the most severe form where they have multi-system organ involvement. A lot of those patients have shock or cardiac involvement. So this spectrum of disease is definitely something that we're all learning about. And I think we'll continue to, our knowledge about this will continue changing as we see more and more of these cases. Based on this information, the World Health Organization put out a scientific brief, and they established a preliminary case definition. To meet criteria, patients have to meet all 6 of these criteria. So that is being a child or adolescent 0 to 19 years of age with fever for more than 3 days. They need to have at least 2 of the following physical findings. So that's rash or non-purulent conjunctivitis or mucocutaneous inflammation signs, hypotension or shock, features of myocardial dysfunction, evidence of coagulopathy or acute gastrointestinal problems. After they have 2 of those, they need to have elevated markers of inflammation, they need to have no other microbial cause of inflammation, and they need to have evidence of COVID-19, either by serology, by a PCR test, or likely contact with patient with COVID-19. When I was thinking about this case definition and thinking about the resources that I had available working in MBEA, I thought that it might be challenging to definitively establish whether or not a patient meets this preliminary case definition with the diagnostics that we had available. So I think that is one potential challenge. The WHO case definition differs a little bit from the CDC case definition, and at the end of the presentation I put a comparison, but the CDC case definition is similar. It just requires that patients have to be sick enough to be hospitalized and show signs of multi-system involvement. Some of the basic evaluation that's ideal to do if you're suspecting this, it's great to get kind of a basic evaluation. This screenshot is of what the UpToDate is currently recommending. To test patients for COVID-19, then test them for other viral and bacterial pathogens, and ideally evaluate their cardiac function. Some common findings amongst their available case series include a low white blood cell count, as well as elevated markers of inflammation. And then just briefly on management, what everything I've seen so far is that these patients can be really quite ill and benefit from multidisciplinary complex care with input from pediatric infectious disease, rheumatology, and intensivist specialists. I think if I saw a patient and I suspected this condition while working in MBEA, I would definitely reach out to our colleagues at Texas Children's Hospital to get some of their expertise. In many cases, the North America seems to be ahead of Sub-Saharan Africa in terms of the peak of the pandemic. So I think it's also possible that the peak of MISC cases will occur in North America before Sub-Saharan Africa. So it'd be great to draw on their expertise if you're seeing a patient with this condition. Right now, they are recommending antimicrobial therapy, especially if you're in that time period where you're not sure if the patient has bacterial sepsis or not. Maybe you've drawn a blood culture, you don't have results back, and in which case you'd want to make sure you're giving your patient broad spectrum antimicrobials. And clindamycin is recommended if they have features that are suggestive of a toxin-mediated illness, such as erythroderma. Some patients are being treated with antiviral therapy for those who have evidence of ongoing COVID-19 infection, but this is really a nuanced question and it varies site by site. So it's great to talk with an infectious disease specialist and think about what resources you have available. And then additional therapy is based on clinical presentation. So patients who meet criteria for Kawasaki's disease are being treated with IVIG, with aspirin, sometimes with glucocorticoids. At the back of the presentation, I put the algorithm of how to approach treating a patient with Kawasaki's disease. It includes the dosing for those substances. Patients with myocardial dysfunction are getting inotropic support. Those with thrombotic complications are getting directed therapy at thrombus. And then other adjunctive immunomodulating therapies are really, again, case by case, ideally with the input from pediatric infectious disease doctors and rheumatology. Amongst the UK cohort that was shared with the CDC call, all of their patients were quite ill. All were admitted to the PICU, all required fluid resuscitation. 70% of patients required inotropic support, and almost 70% you can see required ventilatory support as well. A lot of their patients got IVIG, but some did not require IVIG and did improve without it. So now we'll take a step back again, thinking again about your differential diagnosis that we started with at the beginning. So say you have convinced yourself that COVID-19 is in your differential diagnosis, kind of what next do you do? So the first question is testing, is it possible? And that I think will vary a lot based on your site, what's available, thinking about some of the cascade and the barriers. If your patient has mild symptoms, what do you do? We'll talk about each of these a little bit more, but should include prevention of transmission to others and some anticipatory guidance, some supportive care, and then what do you do about the other conditions that are on your list? So a little bit about transmission prevention. What we're recommending, particularly for patients in the United States, is home isolation. Ideally, patients should stay in a separate bedroom, use a different bathroom, lots of hand washing, masks if they absolutely have to leave the home. In a setting where patients can't be retested, right now the CDC is recommending home isolation should be at least 10 days and at least 3 days since symptoms have resolved, which they define as fever, no fever without the use of any anti-fever agents. When patients are on home isolation, they should try to avoid sharing items with other people, try to avoid interactions with people at higher risk for the disease. But as I was thinking about this, and I think this is something that each site will have to think about, is what is practical for our patients. We know some of our patients might not be able to stay in a separate bedroom. It might be difficult for patients to avoid interactions with people at a higher risk for disease if they're cared for by elderly grandparents. And also thinking about the fact that most of our children, at least in the available information we have so far, who are infected by members of their family. If they are sick, then perhaps other members of our family are already sick, and so they may all need to ideally isolate together. Certainly hand washing and more hand washing and teaching patients about that is a pretty easy, low-cost intervention that can have lots of other positive health benefits, even if they don't have COVID-19. I think it's good to give patients anticipatory guidance about what to watch for. It's, I think, important to talk to them about the potential for symptom worsening, which can occur after 1 week of symptoms, so good to let them know about that potential timeline. Try to give them advice about their child's risk for developing moderate to severe disease. You might tailor your anticipatory guidance based on what you know about that patient, their age, do they have other risk factors like a low CD4 or chronic lung disease. I think it could be helpful to specifically review some warning signs of illness, talk about what are signs of respiratory distress in kids, talk about physical findings associated with shock, and then maybe send them out with a prescription for Panadol or talk to them about fluids and oral intake. But we also don't want to forget about the management of other conditions on your differential. I think as we talked about the symptoms and as I learned about this, what really struck me is how the big overlap between symptoms of COVID-19 and other serious conditions impacting our patients. Bacterial pneumonia, sepsis, malaria, diarrheal disease, TB, chronic lung disease exacerbation could all be on our list and are all important things we don't want to miss. I think this is an area where the COEs are really shine and do a great job of taking good care of common childhood conditions, using our WHO guidelines, using our national guidelines, but we really don't want to forget managing the other conditions. In particular, bacterial pneumonia amongst HIV positive kids can be especially devastating. This meta-analysis looked at HIV positive children who get pneumonia and found that they have about a 6-fold higher risk of being hospitalized and also a 6-fold higher risk of death. So treating bacterial pneumonia is certainly very important. Even while COVID-19 is on your differential, we don't want to not treat the other conditions that you're thinking about. And just to kind of close, I think we've seen some of the the warnings put out by UNICEF about the potential impact of the pandemic on fragile health systems. Some of this data came from modeling done by a group which was published in the Lancet. They estimated effects of decreased access to maternal and child health interventions, as well as increased wasting with economic impacts of the pandemic. And with those two scenarios that they're occurring in varying proportions, that a large increase in under 5 mortality could occur around the globe. And this is one area where I think the COEs do, and all the sites really do important work to provide essential care to kids and mothers to try to prevent this from occurring. So I want to say to everyone to keep up the good work, keep taking really good care of your patients and helping to reach our patients who are particularly vulnerable in this situation of a pandemic. So just to summarize, we talked a little bit about some of the clinical presentation of COVID-19 in pediatric patients, including some of the common symptoms, some dermatologic considerations. We talked briefly about the new multisystem inflammatory syndrome in children. We talked a little bit about some considerations for outpatient management, and then briefly touched on the pandemic impact on child mortality. And thanks very much, everyone, for listening. I will put all of the articles that I looked at in a folder that will be on the box. So if you want to look at things later at your own time, please feel free. That's it.
Thank you so much, Liane. Let's open it up to questions and comments, reflections. Feel free to unmute yourself and speak up. We had some hand claps for you, Liane, from the group.
Okay, great. I think, one takeaway for all our clinicians on the ground is that there's so much overlap that I think it's very tough to say if a patient's got COVID-19 or not. So I think in a situation of a pandemic, to think about every patient as potentially having it, and then take the steps that you need to keep yourself safe with PPE, which I know has been a big topic of other presentations, but there's just a lot of overlap. And I think it's really hard to tell if your patient's got this condition or not. So just keep it in the back of your mind as you're thinking through your differential diagnosis.
Thank you so much, Liane. That was wonderful. And this is Heather. I thought I could just share a little bit about our experience at Texas Children's Hospital. So I think many of you know that I'm a pediatric hospitalist, so I take care of children who are admitted to the hospital. So not on an outpatient basis, but those kids who are requiring admission. And Texas Children's has now started testing every single patient who's admitted to the hospital because we have the testing capability. And I think also just in an effort to help conserve PPE so that once we know somebody's negative, we can limit our use of PPE, and just so everyone can stay safe. So far we have a positivity rate of about 2.3% of all tests that are being run by Texas Children's. So really a low positivity rate. We also have right now a relatively low positivity rate in the Houston community. So, in other settings with higher prevalence, they may be seeing a higher positivity rate in children. I wanted to point out that article that Liane shared talking about the experience of critically ill children across the US and Canada was written by a TCH physician, and we do have a great body of expertise here, I think, that would be available to help you think about cases going forward. Last week when I was on service for pediatric hospital medicine, we did have a case of the MISC, and this was a 16-year-old patient who was initially admitted to the critical care unit with multi-system inflammatory syndrome, and ultimately did not have any positive COVID testing, but did have history of exposure to somebody with COVID, and so therefore met the case definition. And of course, with our antibody testing, the sensitivity is not 100%. So there's possibility that there's a false negative with the antibody testing. So our working diagnosis for that patient, and we ran a lot of other tests too, was the COVID-associated MIS-C. And I think the MIS-C, what we're seeing in cities across the U.S. is that it's mostly a post-infectious phenomenon. So the cases of MIS-C are peaking after the actual epidemic peak of COVID cases, and the MIS-C cases are lagging behind by a few weeks, since we think that this is predominantly a post-infectious phenomenon. And then I guess we've had, I don't know the exact number, but less than a dozen actual cases of COVID that have required inpatient admission. And they're getting sent to Texas Children's. We have a special isolation unit. We have had, to my knowledge, just one death amongst patients with COVID-19. And that was a patient with a lot of underlying conditions and comorbidities. So I think one thing, as Liane commented on, that's going to be different for the settings that you all work in, is that, of course, there's higher rates of lots of comorbidities, including HIV, but also TB, malnutrition, other diseases. And so we don't have great data about what COVID looks like in those children.
Thanks so much for sharing, Heather. That's really interesting about what's happening at Texas Children's Hospital. Great. Well, I hope this was helpful for people and interesting. Yeah, the resources and everything will be on Box. Yeah, thanks for listening. Thanks for attending. And thanks to anyone who listens to this later in the day if you're in a time zone where it's really early still.
Yes, thank you so much, Liane. I know you had to get up extra early.
No problem.
To facilitate this. So thank you very much. And we really appreciate you pulling all these resources together and helping us think through what this might look like in our settings, in the various BIPAI settings. And if you haven't had a chance to access Box, or if you're having problem, please do send me or Catriona an email and we will set you up. Just a reminder to please fill out the feedback form. We greatly appreciate it. And we will meet next week on Friday at the same time as well. So with that, I hope you all enjoy a great weekend. Thank you so much.